think welcome to our second webinar of this lockdown. It's my pleasure to be joined this week by Colleen Winstanley, who's in my upper left screen, probably something completely different for you, but you'll be able to see out the window the beautiful Gold Coast. So Colleen's over in Australia with the Warriors. Julie Shamlaye looking very corporate in her Axis theme scrubs. And we've got Sarah Beable fresh out of level 3 in Queenstown. So thanks to you guys for joining us tonight and for putting some talks together. Just before I get started, I just wanted to let you guys know that we're changing our clinics and the way that we're running our clinics. So we have set up a whole bunch of acute slots and acute sessions. So we're quite mindful that patients don't have as much choice or may not want to travel out to see their GPs, go to A&Es, and probably the A&E doesn't want them there either. So if you're thinking about referring patients, we do have every day some acute availability to see people with acute problems. And I'm not sure also whether you guys have seen the correspondence regarding imaging. So there's been some changes around imaging guidelines in level 4 and some much more prescriptive definitions of what an acute service is. So anything that requires imaging within the 6 weeks is now able to be done within the community. So beyond that, still best to defer. So look, also if we're using the webinar tonight, for those of you that haven't done it before, if you want to ask some questions, we're trying to keep these pretty interactive. So have a look down the bottom of the screen, you'll see a Q&A tab. So if you post your question there, I'll be having a look at that. I have figured out or remembered how to use it. So I think I'll be able to do it this week. And the other thing is I'm going to post a question about what you guys might want from next week's webinar. So we decided to keep this going through level 4, mostly because we've got nothing better to do. And it seems that possibly you guys don't either. So we'll keep the webinars going. So if you could vote and maybe let us know what you might like. If you've got any specific topics, post that into the Q&A. And we'll see what we can do for next week and the week after. So keep an eye. I'll launch that now. So if you just have a look at the poll that's down the bottom as well in the middle, might have popped up on your screen, you can have a vote and I'll give you some feedback. Anything but a COVID topic is looking pretty positive at the moment. Anyway.
Panelists can't vote.
So far we've got anything but a COVID topic is leading 128-0. So maybe we'll do that. We'll do that, eh? I was actually thinking about something that was vaguely COVID related, like looking at some overuse injuries based on things that have happened to people during lockdown. I know that Adam Castricum is very interested in the management and treatment of stress fractures, so we might roll that out next week. But someone voted for, sorry, 2 people have voted for something about COVID. We do have some, anyway, I'll stop talking. Cole, I'll hand over to you. So Colleen is with the Warriors in Queenstown, and she did a fascinating talk for us after the last season when she was away with the Warriors last year, just about her experience and just thinking about trying to travel with an elite sporting team in a different country for a year, the sort of shenanigans that rugby league players get up to the best of times. So good yarn. So hopefully, Cole, you can condense those down into 20 minutes and maybe tell us something a little bit about COVID that we don't know as well. So we'll hand over to you just now.
Okay. I'll just share my screen. All right, does that look like it's going to work?
It looks beautiful.
Excellent. So for those of you who don't know me, I'm Colleen. I'm a sports medicine registrar, and I'm usually based at Axis in Auckland. Currently, I'm in Queensland in Australia with the Warriors NRL team. It's my second year as the team doctor for them and my second year over in Australia. I did get home for a little bit after last season. They relocated there because they're the only New Zealand-based team in the league, and the NRL really didn't want to lose any revenue from any missed games or any problems that would come about from the kind of volatile trans-Tasman bubble. So we are over here. So I'm just going to talk a little bit about just kind of what life's been like and also some learning points that I got from kind of being over here. So I first came over in April, and that picture on the top left, we travelled over when the Trans-Tasman bubble was open. Life was pretty much normal. We were based in Central Coast in New South Wales, and we could pretty much live normally. Last year we were under really strict protocols. We couldn't leave the house other than for training and games, but the start of the year looked pretty good. At that point, the plan was that we would come home in July and we would play some games at home, but unfortunately that didn't happen. In around June, there was a limousine driver that was driving some international workers around Sydney, and he contracted COVID-19. And suddenly the cases began to go up and up, and the NRL got very worried again that the competition might be compromised. So with just a few days' notice, they relocated all the NRL teams to Queensland. We all pretty much were told, look, you're getting on a charter flight, and you're going to be going into a hotel with 4 other teams. So we were kind of in the Gold Coast hub. So we were with the Bulldogs, Eels, Rabbitohs, Canberra Raiders. We were all put into a hotel together. And we were again told, look, you can't leave your rooms unless you go into training or games or meals, pretty much on quarantine, 14 days quarantine with testing every 3 days. And the plan of going home and playing some games at home went out the window. The players all moved up, but the families moved up a little bit later, and they stayed in another hotel. So currently, so as I talk to you, that big tall building in the middle, I'm on the 10th floor. So I mean, it looks pretty nice. It's not a bad place to be stranded, but we're in Surfers Paradise on the Gold Coast, and we're still playing games and still training. We're under strictish protocols, but I mean, I wrote this presentation yesterday, and there was no COVID around. There was 0 community cases. However, there is 1 today. So I think things might change as Queensland seem to act quite quickly if there are any COVID cases and lockdown quite quickly, as do the NRL. But currently we are living here as a team, as a group. I think there's about 70 of us here, including players, staff and families. Every day we have a checkup, so we complete an app. That's what that big green tick is, to say we've got no symptoms. We have our temperature checked to make sure that we have no fever. And if anything is positive, I get an alert saying, look, you need to isolate this person, get them tested, and keep them away from the team until everything's clear. We are under some protocols, but we are allowed out in small groups to restaurants, cafes, and we can exercise outside. So it's still kind of much better than last year, even now. The thing at the bottom is the MIQ for New Zealand. So our last game is actually on Sunday, but at the minute we've no return date. There's no spots in MIQ. When the Trans-Tasman bubble closed, they were fully booked until November, and because we'd been part of that bubble, you know, we just couldn't book anything at all. The MIQ's now been paused because New Zealand is putting its own community cases into those hotels, and kind of for the foreseeable future, there's not really any spaces, and the New Zealand government is quite rightly kind of treating us like other people that are trying to get home. So we're in a bit of limbo at the minute. If anyone's got any questions, just okay. So Fulch said, you know, just talk about maybe some of your main learning points from your trip. I suppose a massive one is mental well-being. The team's been, for a period of a couple of years now, gone through big periods of isolation and separation from families. It's a really uncertain and stressful time. The NRL has a dedicated wellbeing department, and each club has a wellbeing department that that is in constant contact with the players and making sure that, you know, if there's any concerns, it's addressed. They do things like they have access to psychologists, they have access to kind of workshops relating to relationships, gambling, alcohol. So there are a lot of resources there. One thing I found really useful was simple screening tools that I use for everyone twice a year. They are the PHQ-9, which is a depression screening tool, and the GAD-7, which is for anxiety. And it's good as a conversation starter. A lot of people don't bring up any troubles they're having when you do your normal medical. And quite a few things have cropped up just from those screenings where people have been able to access help that was needed. So that's been fantastic. This picture is me and a few staff and players completing the mental health first aid course. That's been fantastic. It's essentially a course that teaches you kind of to recognize someone that might be having trouble, how to start conversations, how to ask difficult questions, and how to guide them to access help. And it was fantastic that the players got involved. In this environment, you may find that there are some players that just won't approach you if they're having trouble, but if there is other people in their team that they can go to, then it's so helpful. One thing, so anyone working with teams, if you've got any opportunity to do a course like that, I think it just gives you that confidence to kind of know what to say and how to approach things when there's a problem. And the bottom line, the RTP decisions relating to mental well-being, I think you talk about psychological readiness to return to play. And I think previously I've thought that that's been people's perception of how recovered they are from their injury. But I think also when it comes to other things that are going on in the background, so for example, people's families being separated, some in MIQ, and some having troubles through the relocation. I think that also, when we reviewed kind of the way we assess RTP this season, we said, well, actually, the broader picture needs to be considered, especially, you know, if people's minds are elsewhere, whether they're ready to return to play or not. Okay. Next one. All right. So be prepared. I know it's quite broad, but essentially things happen so quickly here. One day we're training as normal, the next we're on a chartered flight. So if you're not prepared for the worst, then you're gonna come into trouble. Things like PPE, if you wait for there to be an outbreak, you're not going to get your hands on any. So we pretty much, even though we travelled over and the Trans-Tasman bubble was open, there were no protocols, we just made sure we had heaps of masks, hand sanitizers for worst case scenario, because as soon as there is an outbreak, you can't get your hands on it, and things being delivered are delayed. And the same with medical kit as well. I just made sure that I had kind of plenty of stock, because I know as soon as things kick off, you can't get your hands on things.
So that PP question, Cole, that's probably a good one for us all to think about when we're thinking about planning for the next 18 months. Ordering masks, while there's probably plenty around now, there may not be next year. Is that's sort of your experience?
Yeah. And that was certainly the case when we were talking amongst kind of CMOs. It was like, well, we've not got any masks, and we just kind of stocked up. So we were in a good position. But you know, we've got hundreds of N95 masks now, but they were a bit delayed in they were supplied by the NRL, and there was a bit of a delay, so we had to go with what the club had already arranged. The other thing is just preparing the players. Make sure they've got something in their car, a bag of masks, hand sanitizer. The media kind of hound the NRL, and players, through sometimes no fault of their own, will end up in a situation where they should be wearing a mask and they've not got it. If they get photographed, that's them, standing down for 14 days.
So, Cole, have you been photographed without a mask? Perhaps on your first day at work?
No, unfortunately, I did get photographed with my mask on. It had slipped down below my nose. So it was kind of like that picture, you know, with the man with his underpants on. And
on your first day.
My first day at work. So that was in, I think it was, I don't know, what some New Zealand newspaper had me in it. I just thought, oh, how embarrassing. Anyway. Yeah, so just making sure the players are prepared. And then the last one, just efficiency around testing. Simon Baker touched on this last week with his talk about the Olympics, and that there probably is underreporting of symptoms. And I think a lot of that is to do with the fact that they know there will be a delay whilst they're waiting for tests, whilst they're waiting to go for tests. So we've tried as much as possible to condense that process. So as soon as something's reported, they're tested immediately. We have links kind of with the pathology people to just be able to drop the test off and get it through, you know, as quick. Basically anything that we can control that speeds things up. I know that, you know, you can't control a lab, and we've tried to do that, and that kind of hopefully means that players have more confidence in reporting symptoms, as they know that it's not going to be a 2-3 day wait for a result to come back. Okay, so pretty much the NRL haven't got any special treatment when it comes to vaccinations. They're just eligible when the rest of the public are eligible. And that's kind of happening around now. So the majority of our staff have managed to get vaccinated, and some players are coming through. The big thing I found is you can kind of educate people around the need for vaccination. You've got young guys in the teens and 20s, they're on social media a lot. They click on one conspiracy theory and an algorithm does its thing, and that's all they get fed. So there's a lot of misinformation around there. And I think if you get very defensive and try to kind of shut them down, and the conversation will just stop. So what I've found is just to kind of have multiple small conversations where you're giving them true facts and kind of guiding them towards vaccination, rather than getting into arguments. I think that's been something that I've kind of tried to be persistent about with a certain few of our players. We don't know what the NRL policy is going to be around vaccinations. We're pretty sure that it won't be mandatory, just they can't do that. But looking kind of around the world, particularly say the NFL in America, it gets quite difficult for those that aren't vaccinated. It becomes quite inconvenient. They have to be tested every single day, and they're not allowed into certain areas of the club that other people are, and they have to have separate trainings and stuff. And I'm not sure what the NRL will choose to do about that. But there's a few players that kind of are reluctant to get vaccinated, but as soon as you mention inconvenience, then kind of that is almost a bit of a carrot for them to get it done. Okay, so 24-hour medicine. So pretty much I've been here since April, so 5-6 months. And I suppose that there's good things and bad things around being in a group of 70 people for you know, pretty much living in the same apartment block all that time. The things that I found is that I'm probably too available, and you answer the calls, you do what you can, and I think you need to set boundaries around that. And I think that's beneficial for you and the player. I think it works vice versa. They'll contact me, and then I will also say, oh, I've got a HIA to do, are you free now? And it's their day off. So I've kind of tried to be a bit mindful about invading their free time as well. The families that are here, I don't feel that that's within my scope of practice. I've set up a GP clinic that will treat them. If I was at home doing this job, I wouldn't be treating the families. And so I don't think it's appropriate for me to do that here either. There is a big risk of corridor medicine. just kind of getting stopped. Hey, what do you think about this? And whilst you want to be approachable and obviously not ignore people, I think it's just important to make sure you follow that up with an actual consult with appropriate clinical notes. And there are a few serious things that we've picked up here, kind of amongst staff that have started with a corridor consult, and if there wasn't proper follow-up, things would get missed for sure. You're on a roller coaster, it's up and down, depends what the results are. If you can find ways to kind of level yourself, that's good. I mean, things like meditating, I don't do it myself, but I think, you know, I possibly should. And I make sure I exercise. This is my jog route, which takes me past the Southport Surf Club, which Fulcher's told me that as soon as I'm out of protocols, I have to go in and have a schooner. So I'll do that. And so just, you know, making sure you look after yourself. And then finally, be adaptable. It's a rapidly changing environment. There's, you know, like I say, one minute you're fine, next minute you're on a flight somewhere, 1 minute you're training with full numbers, the next minute, and probably when a few months down the line, it may well be that, you know, 5 of your players are close contacts, you've got a case of COVID in your team. Everyone's got to be able to adapt to that. So whether it's the coaches just acknowledging that, you know, your training numbers are going to change, you acknowledging that you can't kind of make firm plans and lose it if they change. You've just got to kind of go with the flow a bit. Injury risk's gone up this year, particularly with having to travel and play on the same day. So you've got players, particularly kind of soft tissue injuries relating to just being sat down for 4 hours before you play a game and having really poor recovery. So just knowing that that's probably going to happen and you can't change that, but what can you change around it? Can you be making sure your players are getting up, going for a walk? Can you make sure that they have kind of activation and you know, compression garments to help with recovery, and just focus on what you can control, because there's so much of it that you can't control. I think last year I definitely went grey a bit because I was just worrying about things that I couldn't control. So, you know, what if the players don't do the protocols and they get locked down? You can't control what other people do. You can only educate and do your job to the best of your ability. These pictures are that's us on the first day of training and not really going to our first day of training up in Queensland and not knowing what the facilities were. So I had my emergency bag and everything with me because I'd tried to be prepared. And we got there and it was 2 tents and 3 portaloos. So if I hadn't have kind of had my own travel stuff, the facilities, you know, weren't up to scratch. All right, that's me.
That's awesome, Cole. Hey, I've got a really good question for you. So we've got a all-female panel tonight, which is different to last week. We had an all goose panel last week. Anyway, how many women are working as doctors in the NRL?
So I'm the only kind of lead doctor. There are a couple more assistant doctors that are around, and they're our registrars as well. Up here, they've actually brought in some hub doctors that aren't usually NRL doctors, and one of those is a sports physician, Rachel Taylor, so she's up here as well. But I'm the only normal kind of
normal.
I don't know. Regular.
Also, there hasn't been too many questions. I realize it's probably because no one can understand what you're saying. Colleen's a Bolton fan from the north of England. So how about, did you come across many, if any, I'm not sure if that was a gag, players with chronic pain, and how do you approach such a situation with the coaching staff? So I guess we're talking about things like regional pain, maybe people with more pain than you think they should have.
Yeah. So yeah, I mean, there's no one that's kind of had to deal with that throughout the season, but definitely coming back from injury, when people kind of have ongoing pain and the coaches are pushing for them to get back. Often it's kind of a bit of a round table with the coach and the player, as to particularly, you know, if it's an injury that's nothing's going to get worse, you're not causing the player any harm by them playing, and it's just about kind of ensuring the coaches are confident, that the player's confident, that they can return and they can still perform. I often get a lot of comments about players and what they look like on telly, and oh, they don't look any good. I'm like, oh, okay, I'll judge off what the TV shows. But I think you just get to know people's personalities and how they deal with kind of their injuries and pain.
Cool. And then maybe just the last question, but what's the view of game day safety? So I've noticed on TV, a lot of mask wearing from support staff, but are they not in the same bubble? So what's the rule on who has to wear a mask and who doesn't on a game day?
So game day at the minute, everyone has to wear a mask when they're indoors, unless they're warming up. So even the players have to wear a mask indoors. And when we're on the sideline, all support staff and even the people that are running on the pitch are wearing a mask as well. And that's just been mandated by Queensland government.
Half time in the dressing room?
Yeah.
Mask. And I thought you raised a really good point, I reckon, around that well-being and frequent touch points. So I'll maybe post something on our Facebook page, but there's an interesting article that I think has relevance to our practicing life and the value of regular check-ins and regular touch points with patients during the last lockdown. And so I think we shouldn't feel bad about potentially contacting our patients or being in touch with them more frequently than we have done before, because that's one of the things that really has been shown to help people through the last lockdown. So that's something that I think maybe we can all incorporate into our practice, and potentially those mental health screening tools, we could post those as well. So I'm not sure whether people are interested, but certainly if you don't ask, you don't find out. So thanks very much for that. I'm going to switch your screen off and you can have your Corona. Oh, actually, I'm trying to share my own screen. Oh no, things have gone horribly wrong. So I think we're going to have Julie next. You might briefly get my screen. Julie, do something. Oh no. Technology share, fail. I think you're going to have my screen just for a little bit of, something fun. And I'll try and get rid of that again. Stop share.
How's that?
Freak out. Julie, there you go.
Go back to the top. How's that? You got that?
Yeah, that's great. So Julie has a special interest in dance injuries. So if you're seeing patients who are actively involved in dance of any kind, she might be your person to send them to for their problems. But the idea here is to just get a bit of an overview about the types of problems that dancers have. That's the general idea, Julie?
Yes, and a little bit more. We'll see. Thanks for having me. I'm really pleased to be talking about dance medicine because this is a favorite topic of mine. And that really comes from my own background in dance. I did quite a lot of dancing growing up, and I carried on with it on and off over the years as well. My interest is in a fairly broad range of dance styles, but tonight really I'll focus on ballet. I imagine most of you will have seen dances in your practice, and maybe some people more than others if you've got a special interest yourself. Either way, I hope there's something that you can take away from this talk that will be of interest to you. So what we'll do is this. I'll briefly mention some things that I usually find is useful to include as part of a history when I assess a dancer. And we'll go over some relevant technique issues in ballet and how you might assess for those. I've got a couple of cases, and if there's time, and there might not be, but if there is, we'll just do a quick overview of other common dance injuries. So first of all, when I see a dancer for the first time, as well as my usual history, I then also I find it helpful to understand what kind of dance styles they do. So of course, not all dancing is the same. And so the risk profile varies. So for ballet dancers, they tend to get a lot of lower limb injuries, especially foot and ankle injuries. Whereas contemporary and jazz dancers, injuries are a bit more varied. The similarities with ballet is that they use the same degree of plantar flexion in the ankle, but they're not on point, which is that the French term meaning to dance on the tips of the toes. They're often barefoot rather than in point shoes or ballet slippers, and they're not always turned out, which ballet dancers are. And then tap and Irish dancers who dance in hard shoes may be more likely to get problems like plantar fascia pain or sesamoid injuries. And then you've got break dancers or hip hop dancers who are more likely to get upper limb injuries. The other area that's important to explore, particularly because dance overuse injuries are so common in dancers, so just as you would with any other sport, exploring their dance-specific loads is quite helpful. Also, adding all their hours of dance together with any non-dance loads that they might have, because obviously they may do all other types of sport as well. Understanding whether they've had any recent changes to how much they're dancing or the types of dance that they're doing. And there may be some other factors that might be relevant as well, such as has there been a change in the type of floor that they're dancing on? So I think that's particularly relevant at the moment with us being in lockdown. Dancers aren't going into the studio where there are nice sprung floors, so people are dancing on floors at home that are probably not all that appropriate for dancing. So that does increase risk of injury potentially. The thing that is particularly relevant in young dancers, I find, is understanding whether they've had a recent switch to dancing on point. So I'll specifically ask young ballet dancers when they started dancing on point, how long ago was it, how much time they spend on it per class or per week, and get a bit of an idea of whether that transition has been smooth, whether it's been appropriately gradual, and whether they've had their point shoes properly fitted as well. So dance classes, they vary in length from usually about 45 minutes to an hour and a half each. And so you can work out how many hours dancers are spending in class. They may be dancing several dance genres, so that all adds up. And also if they're preparing towards an exam or if they're preparing towards a rehearsal, towards a performance, they might be doing more rehearsals as well. So that adds up as well. And then just to mention the last point there, it's often relevant to explore the possibility of energy availability or energy deficiency in dancers, because it's just so common, but I won't go that into any more detail because obviously this is something that Sarah's going to talk about. And when I examine dancers, there are a few dance-specific things that I find helpful to look at. So first of all, I take note of their standing posture and their pelvic tilt. I then ask them to rise up onto their demi point, asking about whether they have pain in that movement or at the top of that range. And I look at their ankle and foot posture as well. And I find it's quite helpful to use ballet-specific terminology here. So instead of asking them to just go up onto their tiptoes, I like to ask them to rise onto demi point. I think using that terminology can help with building a bit of rapport. And so dancers seem to quite like that. I then ask them to show me their best turnout. So the turnout is that picture, the lower left picture there. And this is an integral part of ballet technique. So it requires external rotation of the lower limb so that the inside of the leg is visible from the front. Now, just like in this picture, 180 degrees or close to it is the ideal that most dancers aspire to, but it's actually really difficult or sometimes impossible to achieve that without actually compromising technique. 60% of external rotation should happen at the hips and the rest in the rest of the lower limb, and most of that at the ankle. And then from that position, I'll ask dancers to perform a demi-plie or plie, which is a French term meaning to bend the knees or to bend. And so that's just looking at whether there's good alignment of the knees over the toes. And then also it's quite helpful to just get a specifically take note of their passive hip range of motion and measure that in supine line with the hips flexed to 90 degrees. Now going on to some common errors. So forcing turnout. This is the most important one to understand because of its associated risk of injuries. It can cause, or it can significantly contribute to just about any dance injury that you might see. A key part of injury prevention, therefore, is to educate dancers about turnout technique. So what happens is the foot rolls in or overpronates, and this overloads the great toe and the sesamoids. It causes overload to the medial ankle structures, including your FHL and tibialis posterior tendons. It compresses the lateral ankle. It applies a torsional force to the tibia, which can lead to medial tibial stress syndrome or stress fractures. And then what you might also see in a young dancer when you ask them to show you their best turnout is this thing termed screwing the knees. So where they place the feet in first position with the knees initially bent, and then they extend the knees, maintaining the feet in that position, so forcefully maintaining the position of the foot. And this causes a valgus knee stress, and so this can lead to various knee problems, including patellofemoral pain. And then there's also an associated anterior pelvic tilt in their attempt to try and maintain that position. And that's also to compensate for their insufficient external rotation at the hip. And then that also leads to this hyperlordosis, which can in turn increase the risk of developing overload to the posterior elements, such as your pars interarticularis stress injuries. And then the second one there, or the second and third, is sickling. So to be able to achieve a good demi-point position, a dancer needs 80 to 100 degrees of dorsiflexion at the first MTP joint. So sickling often happens as a result of inadequate range here, or weakness, or weakness of the calf and perineals. Sickling in, which is the third picture, is where the dancer's weight is transferred to the lateral toes, and sickling out is the middle picture. There's the opposite. What's also common in young dancers, even in the absence of forcing turnout, is they tend to adopt this excessive lumbar lordosis and anterior pelvic tilt as well, which is important to look out for and just address early. So shall we go on to some cases? Just to mention that the two cases I've got of reasonably common dance problems, and they are common even in the absence of any of those errors that I've talked about just there. So firstly, we've got a 21-year-old ballet and contemporary dancer who's also a teacher of dance. She was first seen by telehealth earlier this year, and she reported a history of inversion injury to the right ankle about 4 months before. Initially, the problem had been anterolateral ankle pain, but this gradually evolved, and that seemed to settle, but what she presented with was deep posterior pain. So on examination, which happened partly on telehealth and then partly at a later date in the clinic, she was seen to have planar valgus feet. She reported pain in the demi-point position. She was most tender both posterolaterally and posteromedially, and her posterior impingement tests were positive. She was also noted to have some perineal weakness. The main finding on her X-ray was of an os trigonum, which is, as many of you will know, is an accessory bone. It's found in about 20% of the population. It's a normal variant, but it can be implicated in posterior impingement, which is what this patient presented with. And her MRI, and I selected one picture here, but you can't really see all the things that it really showed. But essentially, there was a slight amount of increased signal in the os trigonum. And there was also evidence of previous ATFL and CFL sprains. And there was also ganglion and a tear in the PTFL and in the intrasubstance of the PTFL with some surrounding synovitis as well. So all of that, I suspect, was contributing to her symptoms. So this This patient really struggled with her symptoms, and it just wouldn't settle with quite a prolonged period of dance. She really struggled with trying to maintain her job as a teacher. She worked really hard on her rehab. She tried courses of anti-inflammatories. She had a cortisone injection, which did nothing for her symptoms. And so eventually I referred her to an orthopedic surgeon for consideration of excision of the os and the ganglion. So that's where we're at with her. And I haven't heard more recently what the outcome of that was. So she had posterior ankle impingement, which is a very common dance problem, particularly in classical dances. While in this case, the os trigonum was probably relevant to her presentation, often it is just soft tissue impingement, not necessarily bony impingement. It's often a sequelae of lateral ligament sprains, and that's because the increased ligamentous laxity that happens after a sprain means that there's more anterior movement of the talus in the plantar flexed position. And this therefore leads to the impingement of the posterior tibial lip against the calcaneum. So forcing turnout and sickling, this definitely contributes to the risk of developing this problem. And also this practice of forceful plantar flexion, which some dancers spend quite a lot of time doing. They try to either lead with a foot or push their body weight through their heels by sitting on their heels in a kneeling position. So that, it's trying to get maximal plantar flexion in the ankle, but end up just forcing and irritating and impinging those structures posteriorly. And the other important thing to mention with this is that even if it wasn't present in this case, FHL tendon pathology often coexists. So it's important to consider and assess for this every time you see a dancer with posterior ankle pain. So just to say briefly, this is FHL pathology happens because of the repetitive transition from the full dorsiflex position in a demi-plie through to point. And so people usually present with pain posteromedially, with jumping and landing in that transition. And they report pain being worse through the transition rather than at the end point of their demi-point, which is what people will report with posterior impingement primarily. So having an os trigonum or an enlarged posterior process often contributes, because it can compress the tendon as it passes just adjacent to it as it changes direction from vertical to the horizontal. And this can cause thickening of the tendon, and it can lead to triggering, which can present as popping or crepitus due to some tearing in the tendon and tenosynovitis and scar tissue. So how you might assess for this is to look for pain with resisted great toe flexion, or with full passive stretch, so full dorsiflexion of the toe and of the ankle at the same time. I'll move on to the second case, a younger dancer, a 14-year-old, also female ballet dancer. She presented with gradual onset of right forefoot and midfoot pain. She had pain and swelling predominantly in the dorsum of the base of the second toe, and her symptoms were worse on demi-point and on point. She had neutral foot posture. I just noted that she had a slightly longer second toe. She had pain with a single hop, and midfoot stress tests were also painful. She was tender at the dorsum of the second MTPJ, but also at the proximal metatarsal. So her x-rays look normal, but she did have, as we saw when on examination, a longer second toe. So she has a Morton's foot type. So her first metatarsal is relatively short compared to the second. Her MRI, though, clearly abnormal. So there's increased signal in the second metatarsal shaft and the base. Although there's no clear fracture line, she's definitely got a stress injury there. So she has a base of second metatarsal stress injury. And she did really quite well. So with a relatively short period of being offloading, her symptoms settled. She was in a moon boot for about a month. She was out of it once her midfoot stress tests were negative and she was not tender. She could hop and walk pain-free. She was able to continue working on some flexibility and Pilates, which is really helpful for dancers during their rehabilitation. She worked on strengthening of the foot and the calf muscles, and she was able to gradually increase the dance loads again. So this type of injury is actually very common in dancers, in classical dancers. And in fact, it's the most common site of stress fracture in female classical dancers, whereas it's rare or almost non-existent in other sports. So it's one to specifically consider in a dancer. And this is because in the demi-point and on-point position, the first and second metatarsals bear most of the body weight. What I find interesting is this question of whether having a longer second toe or a Morton's foot type is actually important. So there is this assumption that having a longer second toe means that second toe takes more load and is therefore a risk factor for this injury. But actually there have been some studies in elite ballet dancers that have tried to compare the presence of stress fractures in people with Morton's foot type, and they found that there doesn't seem to be a difference in the relative length of the metatarsal, first and second metatarsals, and the risk of stress fracture. So perhaps this isn't actually a risk factor after all, but it does make, I think it does, having a slightly longer second toe probably does make fitting point shoes quite difficult. So that's probably the main reason that that's relevant. But when it comes down to stress fractures, just as with stress fractures anywhere else, it's obviously important to consider other risk factors like nutritional deficiencies and high loads, and not to forget those things as well. And this is my last slide. How are we doing for time, Mark?
Good.
Shall we? This was just briefly.
This is a slide showing all injuries occurred.
Yeah, pretty much. Sesamoid injuries there, just in bold, just to say that this is a difficult one to treat. Dancers obviously roll onto the sesamoids repeatedly when they go up onto demi-point and then on point. And these can be challenging because they often take a long time to settle or they don't settle. So these are the ones that I would refer early, and we want to see them and probably image them and understand them a bit better. But I'll probably leave it at that because, yeah, essentially they can get just about any injury. And I had a special little section there for male dancers who have a slightly different injury profile because they tend to not be on point. So the take-home messages: overuse injuries are common, especially in the foot and ankle in classical dancers. Look out for some injuries that are common and specific to dancers that may not be common at all in the rest of the population or in other sports. Turnout, that's a big one. Look out for that because it's just so important in managing and preventing injuries. Consider referring early. So a lot of these injuries obviously do better if the diagnosis and treatment starts early. And yeah, I for one am more than happy to see dancers, so send them along. And equally, if there's anybody out there who's got a special interest in seeing dancers, I'd be quite keen to hear from you as well, because that collaboration is quite good, I think.
Awesome. So there's a couple of good questions here. The first one is just something that I'm quite interested in. Is, as a clinician who's not a dancer, are there any specific resources we could use to demonstrate these corrections in dance techniques? Is there some books or YouTube or maybe your slides?
My slides. You're welcome. Yeah, that's a good question. I have not actually used any specifically. I think the Australian Ballet have some good resources from what I've heard. But I have been meaning to go and specifically find them. Yeah, that's a good thought.
They certainly have some good online resources about foot
Yeah.
strengthening and intrinsic strengthening. So that might be a good place to look.
Yeah.
There's a couple of questions here around how to reduce load in shoes. Is taping something that could be useful? Padding, those sorts of things.
Yeah, some things you can do even in point shoes and ballet slippers, but it is quite hard. I mean, depending on what the problem is, you can use orthotics and taping and padding in street shoes, which, you know, obviously they're not in their ballet gear all the time. So where they can be offloaded, where those structures can be offloaded with orthotics and things, then I think you should. But it's tricky when it comes to doing making adjustments to their dance footwear.
There's a couple of good resources in the chat down here, and another pump up for Lisa Howell, who's an Australian physio. So apparently those might be some places to look, Cameron. What about the relevance of calf strength for posterior impingement and FHL injuries? Do you think calf strength is important?
Yep, definitely. Yep. Calf strength yeah, FHL to post strength, intrinsic foot, and also external rotators of the hips as well.
Cool. And then just a couple of questions just around the different types of dance. So any recommendations specifically around, well, the one question is, do specific dance genres tend to load dancers more aggressively than others? So I guess the nature of the dance fundamentally is the question.
Yeah, I think, yeah, there is something to the culture of certain dance styles, and also the amount of I guess the amount of training that goes into being able to build the skill. So for example, ballet is one that requires many hours of training to get there. So, and especially if you want to get on point, it's not it's not an occasional thing. You do have to keep up the loads to be able to make the gains in skill. So ballet is one that's particularly troublesome in terms of risk of injuries, whereas others I think can be done more casually. Does that make sense?
So what you're saying is they're not proper dance?
Not what I'm saying at all.
I think that's what you... Anyway, twist and shout at weddings. I think there's a question from Tony Edwards. Is there a particular song that you should avoid? Maybe we'll skip that one, Tony. Anyway, so I think we'll maybe move on. There are a few other questions that maybe we'll get to at the end. So thanks very much for that, Julia. That was great. And I think it's a real good opportunity to get something a little bit different to ACL, sore back. So I really enjoyed that and definitely learned some things. So we'll hand over to Sarah. Sarah, as you know, Sarah Beable is based in Queenstown. Julie touched a little bit about RED-S and energy availability. So Sarah, as I'm sure many of you know, has a specific interest in that. So we're going to hear a little bit about some updates and maybe some thoughts relative to COVID. Just before you start though, have a look at the results of the poll. It was a narrow thing, but I think we'll maybe go for an anything but COVID topic next week. And thanks for those of you who have posted something as a suggestion. So any more suggestions, let us know. Again, I'll stop talking and hand over to Sarah.
Right, so thanks for having me. I'm going to try and keep this as succinct as I can. A lot of you know that when I get on my low energy availability or RED-S rant, I can lose a bit of track of time. So basically, I just want to talk about the kind of patients that I want to see, that we all see as clinicians, and then just talk a little bit about COVID, because I saw a big increase in COVID onset of energy deficiency last year, and some of them I'm still struggling with due to what happened during lockdown. So we'll go through a little bit of that. But for those that haven't heard the term energy availability, this is one of the slides when I see patients, and by telehealth, I see one of these nearly every day, even in non-COVID times, and I show the slide a lot, basically trying to demonstrate that the energy that we get from food and drink is what we have for us to then take off the daily cost of exercise, and what's left is the energy that's available for body function. So that's your bone health, it's repair, it's your reproductive health, your ability to fight off colds and COVID, your hormonal profile and growth, just to name a few. So if you're not getting enough food and drink, you're exercising too much, then basically a lot of these body systems start to shut down. So RED-S, meaning relative energy deficiency in sport, refers to impaired physiological functioning. So things in the body are not working properly because of the relative energy deficiency. Now this can affect women and men, and I've started to see some men in the clinic. A lot of people, a lot of the males that I do see have come from a cycling background or an endurance sport background, but also CrossFit and some of the bodybuilding background. You know, I see some bodybuilders who are expending 4,000 to 5,000 calories a day and eating 1,800, and you can't do that without quite significant consequences. It's far more common for this to present in a female, and that's usually because the most accurate thermometer that we actually have besides general fatigue is the loss of periods, and that's an easier thing to kind of jump on rather than the male population obviously don't have that. They do actually drop their testosterone, but that's not something that they'd go generally to a GP and say, can you check my testosterone, I'm not eating enough. So this balance has become a really important topic. You see it a lot on social media, and you see it a lot from athletes now starting to have these conversations. And back in the day, they used to call it the female athlete triad, and it is still called that, but I guess I prefer the term relative energy deficiency in sport, or RED-S, because that encompasses the male population as well, and I think it shows the spectrum. So the female athlete triad historically was the amenorrheic, or that means no periods, osteoporotic or poor bone density, and often anorexic, and there used to be a lot of distance runners or ballet dancers actually, and now this kind of thought process is that there's a spectrum, and what's probably one of the most important things, and there's quite a bit of, I was doing some reading on it actually last night, is most of the time when I see people with an energy deficiency problem, they're of normal body weight or may even be of increased body weight. Now, a lot of people don't really understand how that happens. And a lot of teenagers will say to me, I don't understand why I'm putting on weight and I'm eating nothing. And I basically tell them that their battery or their car engine has gone flat, and to have a good engine, it needs good petrol. And when there's no petrol, then they become a crappy engine. And so that's when they stop being able to metabolize things. The body thinks they're relatively starving, and they store body fat, and all their processes shut down. I also show parents and teenagers this graph here, and actually it's quite a useful one. If you look at the bottom one, if you look on the left-hand side, this is actually the endometrial lining being shed, which is the period. So that's the start of the cycle, and then you have all the hormones, which you can see above. You've got a spike in estradiol, you've got an LH, a big LH spike, which is around the time of ovulation, but all those hormones are required to build the endometrial lining, and then when they drop off, it sheds again. So if you are not getting enough energy, you do not make these hormones, and that's the body saying that you're in a famine state or a war state, which is basically true. During the war and during a famine, that is not the time that you want to be having a baby, and this is putting the body into this kind of stress as well. So basically we don't get these hormones, we don't make the lining, and then we don't shed the lining. So that's why people don't get their period. So when we look at the effect on athlete health, when I'm talking to people, it's usually, I'm really focusing on the parents when I'm talking about athlete health, because they seem far more interested in some of the longer term consequences on health, whereas the kids often seem a bit more, if I tell them they're going to start swimming slow times or they might break down with injury, they seem a bit more interested in that. But it's got a range of health effects. Growth and development, so people's growth can get slowed down, their puberty development can halt. They can get low iron or hematological problems. There's a high incidence of anxiety and depression. What's becoming a little bit more apparent, which I've been doing some reading on, is the kind of background history of maybe 50% of people with RED-S have some kind of history of trauma or PTSD in their past. So that's something which is actually quite a big thing to deal with in this whole process. You can be poor at lipid metabolism, and it can affect your heart. Nearly every patient that I see with quite severe RED-S have irritable bowel. They've been told they've got irritable bowel syndrome, where actually it's more related to the intolerance of the kind of relative starvation that they've put in. And often what's happening is people are avoiding complete food groups. So they've gone dairy-free, gluten-free, everything free, and then they'll have something in that food group and their body will bloat. So when you completely exclude food groups, the next time you have it, you usually have a reaction. So that's generally because of food avoidance that we see that. Immunological, so increased illness. I see a couple of patients and one, you know, why am I the person that always gets sick? I've had 7 colds this year. Menstrual function, oligomenorrhea, meaning reduced periods. And so sometimes I see people that have 5 periods a year instead of ideal 12, or amenorrhea when they've got none. Sometimes I also see people who are primary amenorrheic, which means they've never had a period. So I got referred someone I don't know, a couple of months ago who was 22 and has never had a period. And really the abnormal age where we want to start seeing these people is anything beyond the age of 15. Used to be 16 and they've dropped it down to 15 now. If they haven't had a period, that requires medical input. I should just say while I'm talking about that Red S is a diagnosis of exclusion. So there's lots of things that can cause loss of period, pregnancy being number one. But there are other things that can cause it. So it's actually other medical things need to be worked out. So it's a really important part, which I'll come back to on why it's important to get a medical consult as part of this whole workup. So bone health is a really important concept. We build our best bone up to the age of 19, 20. Beyond that, we just hold on to it until menopause, and then we try and stem the loss. And so the energy that we're putting in those growing phases are incredibly important. And then I've talked a little bit about metabolism and endocrine as well. But you're far more likely to get buy-in from the athlete if you start telling them they're decreased coordination, they're not going to train as well, their strength's going to be compromised, endurance is going to be compromised, increased injury risk, depression, irritability. When you talk to the parents, I say, oh, they're a little bit grumpy, and they're like, oh, they're not even the same kid. And so I guess it's that whole hangry thing is a real thing. They're permanently starving, they're permanently grumpy. And it's incredible that the actual treatment for this is food. So there's no real magic formula here, but food does work really well. So basically, when I see somebody with this problem, like I said, it's a diagnosis of exclusion, and it's all in the history. I spend about an hour with these people, and good half an hour follow-up, and we end up having a bit of a long journey if it's an intentional underfueling. If it's unintentional, and you see that a lot in a busy teenager who's doing heaps of sport, they just don't know how much they need to be eating, especially females. We've grown up in this culture of 1,500 calories a day is kind of what all our friends do, so that's maybe what we should be eating, when probably for some of these athletes it's 3,000 or 4,000 calories a day, which is a lot of food. So if it's unintentional low energy availability, it's quite an easy thing to fix. They just need good education. We've got a really good dietitian that we use, Dane Baker at Access, so I'm using some of his slides, thanks Dane. But his process of how to educate people on fueling regularly is really, really important. With those people, I don't tend to see them so much, maybe once, a couple of times, and then they're off on their way. And I usually get an email, a year down the track of, I've made this team, I'm feeling great, I'm better at school, I'm much happier. Intentional's much harder, and this whole movement of thin is faster, or excessive desire for leanness, it's pretty hard not to get caught up in that, especially you're in a sport where you're wearing a leotard like ballet, or you're running around in your lycra and triathlon, or you're obsessed with your power to weight ratio and hill climbing capacity. And what I need to tell these people when I do over and over, and these guys need to hear this message from so many people over and over, which is why it's really important that everyone understands the process, because they are in denial, is that stronger and healthier is better than their excessive desire for thinness. So they're far better to be eumenorrheic, or having periods, and in an energy balanced state, they will perform better and they'll have better health outcomes than if they weren't getting periods. And so even though there's a little bit of, when people first drop weight, they start running faster, but then often invariably what happens is they get a couple of stress fractures and they end up with you guys in the physio world, or with us in the sports medicine world. I often get the, but I'm not hungry, and that's because you lose your hunger, drive and energy deficiency. One of the first signs of recovery actually And when people actually, metabolism starts working, is that they're just starving first thing in the morning, and that's a good thing. So you see that a lot. There's a personality type of perfectionism. Usually these are the guys that have their badges falling off their blazer and their head girl of this and head of sport at that, and very, very performance driven. And you know, perfectionism has got some underlying need for control as one of the underlying psychological traits, and so it's a challenging thing to work with. And you know, a lot of these people, they love it when you ask them to do a food diary and show you their training, and you will get their last 6 months of their training diary. So the excessive conscientiousness is quite something that we do see. And again, I've got an athlete at the moment. I found out from, I don't know even how, they asked me to ring her coach actually, and the coach said, yeah, someone in the group said she was running an extra 10K a day, and well, no one could work out why this girl was energy, but she was hiding an extra 10K run a day. So she was doing an extra 70K a week. So you see a little bit of that, which is all challenging to work with. And COVID, I just want to jump on this one. I don't want to, again, take too much of everybody's Thursday night. It's a really interesting and weird kind of time. And so I've just mentioned a little bit about the personality traits that happen with Red S. For those of us that don't suffer from any kind of disordered eating or disordered eating processes, this is a weird time anyway. It's stressful. We, you know, financially, there's consequences for people. We are socially isolated. If you are, you know, not in an energy balanced state, you have an exercise addiction, and now your whole family can watch your exercise addiction and your restricted eating, things can spiral quite badly. And so I've seen a few people that lost 8 kilos, 10 kilos over last lockdown because they now could train 3 times a day, because what else do you do on lockdown? And then they could obsess over their food planning. And once they've got on that track, it's actually really, really hard to get them back on track. And you see this kind of non-functional overreaching, meaning that people are training heaps but not getting recovery, which can then go into overtraining, and then along, you know, that can lead into depression. And so something that I've been trying to talk to people about is the importance, and you see this in the Olympics, the importance of recovery. So recovery is when the magic happens. I think a lot of the reason we saw such incredible performances at the Olympic Games was because elite athletes actually tend to not, they've got very specific training programs, they tend to not overtrain, but what they probably could do in the last 12 months was increased recovery. So they weren't doing the same travel schedules. I'm not saying they weren't having some harder stress and more anxious times, but they probably could plan their food better. They couldn't do all the kind of overtraining things or under recovery things that they would normally do. Whereas what we see in the non-elite population is people going, oh, more's better. And then if I eat this, oh, you know, that'll help because then I'll be faster. And they're training 4 times a day. And invariably we see the spike in stress fractures and a spike in energy availability issues. And then the cycle just perpetuates. So COVID is a big time for this. I'm seeing lots of them at the moment, and I've seen an increase in my follow-ups over the last couple of weeks of people that have reached out and said, you know what, I'm actually really struggling, or they've reached out to their physio and said, hey, I need some help because my bulimia has come back, or I'm training twice a day and I've got this hip pain and I've actually stopped eating and because I'm actually stressed, and you know, my whole family sits and watching me eat and I can't stand it. So there's a lot of really challenging things that can happen in COVID. And so just a wee awareness of that. And just to kind of finish up, I know I'm giving lots of information, but I get a lot of questions from, you know, amazing physiotherapists that want to find out how they can help. And, you know, I hear a lot about people wanting to start their own energy deficiency clinics. And the one thing that I feel is important is to talk about the roles and responsibilities. It is the best thing for physiotherapists to be able to screen for this. It is the most helpful thing for people to get a feeling in their waters and go, you know what, I'm a bit worried about you. I think we might get you sent on to someone else. Doing a LEAF Q, which is a screening questionnaire, is incredibly helpful. And if there is, you know, some positive answers on that, that's a great time to refer to the GP or someone like Access Sports Medicine or myself to really start looking at things. It does need to be medically led, and that's for the other medical things that can cause this. So we have to be able to rule out the polycystic ovaries, the primary ovarian problems, early menopause, a whole bunch of other things that can cause loss of period. But I think the best thing we can do is kind of work together in terms of screening and then onward referral and then working together to manage load. So it's a tricky topic. It's very common, more common in sub-elite than the elites, but as we're seeing, lots of elites are struggling with this. So basically those are my big ones. And just to cover off on a case, just out of interest to keep everyone thinking about it, I saw this fabulous patient who was a swimmer from age 9, and she at 16 had a nutritional input for her swimming team, and it was all about how they could lean up for swimming. And I think 4 of the 7 girls in their squad ended up losing their period over 6 months while they all tried to get a bit leaner. And this girl was now 19, so 3 years later, and she still hadn't had a period for 3.5 years. And she had become a runner in her bid to be a triathlete and was getting shin pain. And she'd been worked up for compartment syndrome and a back issue. And basically, when I saw her BMI had got up a little bit because she'd worked out she needed to be eating more, but she had that classic tiredness, irritable bowel symptoms, was training 20 hours a week with 5 hours of running, and clinically presented as a bilateral stress fracture. And I think when people come in with shin pain on both sides, I think people can sometimes forget that you can have a stress fracture on both sides when you have appropriate risk factors. And this girl had, she was osteopenic in both her hips and lumbar spine, the lumbar spine being negative 1.8. Energy availability tends to affect the spine more than the hips. And so that's a sign that this has been going on for a period of time. Her estrogen is very low at 86, her progesterone was less than 1, which again goes with the low estrogen, so there's no chance she'd be ovulating. She was iron deficient and anemic. So we managed the injury, that's the easy bit really. She, over about 4 months, gained 4.5 kilos, and she had her first period in April this year. And what was really interesting for a 19.5-year-old that she grew 2.2 centimeters in this time. So I think she'd been put into kind of this delayed puberty phase, and then everything just played some catch up and her bone densities improved. So it was a really cool story because she's really bought into it. But it was one of those that had gone on for a long time. So things don't always end up quite like that. So yeah, we can get the energy status back pretty quickly. You start eating more tomorrow with, the only medication we need here is really food. We don't want them on the pill, we want them eating. And then the periods can come back over a period of months, depending how long it's gone for, but the bone density can take a few years. What I get concerned about is how long the disordered eating thoughts and process can take to recover. And for people that have had it for more than 10 years, then I think it's normally lifelong, which is pretty sad if that's how we're going to be trapped into living. So yeah, this whole athletes eat and train, they don't diet and exercise, really good message to keep giving out to everyone.
So thanks, Sarah, and thanks everyone, actually. There are a few questions. I am aware that we're a little bit over time, so we will spend some time going through these questions, but if you're keen to get back to, well, I don't know, what are you doing, watching TV or something there, but I don't know. So if you're keen to head off, we will be doing another webinar next week, which looks like it'll be something not related to COVID. So I hope everyone has a good week. Sarah, are you happy to stick around and answer a few questions, and the rest of you too? So there's a question here from Susan Simpson, and it might be the Susan Simpson from Wellington.
Susan Simpson.
Who, I don't know, Julie, if you've met Susan, but she's the physiotherapist for the School of Downs. So if it is indeed the Susan Simpson,
nice.
Flick me an email and I'll link you in with Julie. So she's just
Brilliant.
asked a question, Sarah, about what blood tests do you suggest doing for patients with this?
So I do a big screen of their first one. So I do all the basics. So I do a full blood count, check they're not anemic. I do their iron. Putting me on the spot, Susan. I do their thyroid, because if their hormones are suppressed, the thyroid can also be. Prolactin is quite important. One of the rare causes of amenorrhea or loss of periods is a prolactinoma. So you want to make sure there's not something like that going on. Vitamin B12, folate, I never really come up with too much from that. I check their estrogen, their LH, their FSH, their testosterone, so polycystic ovaries. One of the criteria is an elevated testosterone, and so I'm always checking that as well. And I actually check their lipids because of and nearly every single one of them has an elevated lipid profile. And I'm also checking their IGF-1 and cortisol to rule out some other rarer causes of amenorrhea.
I think that's a good point though, isn't it? It's not one thing. It's really casting the net and making sure.
Yeah. And then I should have said, Fulch, and I tend to, if they don't have a period, I do them every 5 weeks, the hormone ones, just to see if we can see some recovery.
Quite a cool question around menopausal sporting people. Do they get red S, and what's the story with them?
Yeah, so really good question, very under-researched area. Stacey Sims, one of my colleagues on the Whisper group, has done a lot of work in perimenopause and postmenopause, and very much you see quite a bit of muscle wasting post menopause, and you see, so you lose a bit of muscle. A lot of people start training quite hard with endurance training rather than muscle bone density strength training, which is all really, really important. And one of the key things that we try and teach people in the menopause group, in the younger group, we're like, carbs are really important. You need lots of carbs. You need a lot of protein in the postmenopausal group. So something that's, Stacey Sims has written fantastic work on this if you have a look at her.
Cool. And another question from Anya, which is a good one. If that swimmer who wanted to transition, or say if you get a competitive swimmer, how might you encourage them to train to maintain their bone density?
Yeah, great question, and similar for rowers and things too, is so when you're not getting ground reaction forces, it's a really important consideration, especially in high training loads. So key one is, how much are they doing? Are they doing more than their age? So they're 14, are they training more than 14 hours a week? So if they're doing too much, that's the key thing. You need to be able to eat for the amount of training that you're doing. And then I think 2 strength sessions a week, as long as they're fueling appropriately to help maintain and build their bone density. That's it. That's not, a lot of athletes want to train more, so you don't add in more unless their fueling is better. Otherwise, you're just going to keep going down the spiral.
And maybe this is a tough question to answer in 2 sentences, but broad strokes, what might you do if you've got an athlete that's showing signs of a more serious kind of eating disorder, or at risk of developing an eating disorder?
You're
allowed 30 seconds to answer the question.
So that is a psychological issue. The athlete will likely be in denial. They need psychology input. That is not easy in this country, but we have a good array of people that I try and direct people to, and we work together to try and get some help around the thought processes, because this is a psychological problem.
Yeah, and look, as someone who's far less expert at that, it's very hard when they often don't want to see the psychologist. Any kind of tips about building engagement?
Yeah, I mean, I pretty much tell them at the start, I'm really nice in my first appointment, and I'm not so nice in my second one. I go good cop, bad cop, and I literally tell them I'm going to walk through the journey with them. And part of that is then knowing when I need to push in terms of, bring someone with you. We need to talk about your food plan, but also this thought processes. We need almost a bit of a contract. And the Red Scat published by the BJSM, has got some great resources. You bring that out and you show somebody that they're in the, red criteria or the yellow criterion portion. You stop them training, you might get some buy-in. And we stop people when they've got concussion. We stop people when they've got heart problems. We don't seem to stop people with this, and I don't know why we don't. So I pull people right back. You might get buy-in. They can't do what they love.
One thing that we found really useful in football was having the coach frame this around things in their performance. So instead of addressing things around weight, it's like you're getting bullied off the ball, you're not strong enough. Look, your aerobic running stats are off the roof, you're amazing at running. We don't actually care about you training for your running. Just get stronger and don't get bullied around on the field. So I don't know whether that helps at all.
And if you think of the gold medal winning sevens women's team, their whole analogy they use, and they've done a lot of work around this, is that they're all paddling the walker. So it's all about them having enough strength together to paddle the walker, and they help each other be strong, so that it's all performance based. So it's quite a cool analogy. You see it, the rowing team have done amazing things too. So this whole strong, not skinny, the message is getting there, but we just need to kind of keep all pushing the same thing.
Cool. One last question. from Storm, really enjoying about this, is there any evidence about the long-term impacts of RELES? So does the body completely recover, or is it ongoing impact even after the energy imbalance is recovered?
Yeah, great question. And I do get this one a lot. Look, if we get onto it quickly, there's, you know, if people get their periods back, if you get your periods back, you get progesterone, you're ovulating, you will be able to have a child with all the other things going well, just to simplify it. If this has gone on for a very long time, there's a really good chance that the psychological processes become quite detrimental. Fertility and bone could be compromised. So people can end up osteoporotic in their 40s. They could fall over and break their hip in their 40s. They may not be able to have children. So there are some significant long-term consequences. However, I think that's, you know, less than 5%. I think most of the time we can get people back to having, you know, a normal, healthy life if they get enough input early. But beyond 10 years, like I said, if it's been going for that long, it's a hard thing to change.
Awesome. So look, we might wrap it up there. I think just one last point to remember is that telehealth probably makes some of these guys more accessible than ever before. So Sarah, although she's in Queenstown, is pretty available and pretty able to assess these patients in other parts of the country. Similarly, I'm sure that Julie would be happy to see dancers or talk or consult about dancers. And Colleen, if anyone has drunken rugby league players or buffoons, more than happy to see them live from the Gold Coast. Is that the case, Colleen? Probably not. But anyway, look, thanks very much for your time this evening. I'm sorry we ran a little bit over, but I hope it was worth it. I thought there's some really, really good questions there. And look forward to catching you all in your living rooms, sheds, or wherever you may be next week. Thanks for your time.